goal for today is to help you understand when they say a prospective cohort study, what did they do? So what was the design that they used when they say a prospective cohort study? So the first question is, what is a cohort study? And so we're going to talk a little bit of detail about cohort studies. So a cohort study is when you identify a group and you follow them for some time. So you find a group of people and then you follow them to see what happens to them over some period of time. So when I say I am in a cohort, that is a group of people that move together through time. These are usually observational studies. So we are not actively saying you get the intervention, you do not. We are not randomizing to intervention, but we are just observing what happens in natural circumstances. We are not changing what happens to people, but we are just observing what happens to them under certain conditions. And there's three things that we typically use cohort studies for. One is to estimate prevalence or incidence of an outcome in a certain group. So what proportion of patients had their viral load suppressed in those who had community-based accompaniment? So we want to know prevalence of an outcome. Maybe it's disease, maybe it's retention. And we want to look at incidents, so new things that happen in the group. We also use it to identify factors that are associated with particular outcomes. So who is more likely to be lost to follow-up? Who is more likely to have an increase in viral load? So what factors are associated with a particular outcome? And then finally, for hypothesis generation. And when I say hypothesis generation, I'm trying to find out things that are happening that I want to know more about. So I think men are more likely to be lost to follow-up than women because I look at my data and I need to know more about that. So cohort studies are good at generating new questions, generating new hypotheses of what we see in the community. So there's two ways that we can have cohort studies. One way is you have one group that has exposure, and you have an entirely different group that has no exposure. So I take these groups of people, one with exposure, one without exposure, and I follow them over time. And when I follow them, I say, who had the outcome? So in this case, a star is an outcome. Oops, I'm out of room. Who had the outcome and who did not? And do I see differences in the rates of outcome between those who are exposed and those who are not exposed? And my primary question is there a relationship between the exposure, either not exposed and exposed, and having the outcome? So is there some relationship with having been exposed and having disease? Is there some relationship between having been exposed and being lost to follow-up? Is there some relationship between having an exposure and dying? And I'm looking at the relationship between exposure and outcome. Now it's another way that we can do this. The different way that we can do this is we just have one group. So in the last one I had one group that was exposed and another group that is not exposed. In this case I just have one group. And when I pull that group in, I say, who has the exposure and who does not? So instead of having two groups, one that is exposed and one that is not exposed, Here I have one group, some of whom are exposed, and some of whom are not exposed. So this case, I don't identify you on exposure, but I just have a full group, and when you come into my group, I say, are you male or are you female? Are you young or are you old? And I identify your exposure, being male or female, based on your answers. The other one, I would find a group of all males and a group of all females, and I would follow them. This one, I have one group, and I just ask you about your exposure. But like before, after I enroll you, I follow you for some time, and I say, who has the outcome and who does not have the outcome? So even if you use this way of doing a cohort study, the question is the same. What is the relationship between exposure, maybe gender, male, female, and death? What is the relationship between money, maybe having money and not having money, and the likelihood of death? And so you're looking at an exposure and an outcome and trying to see what the relationship is between the exposure and the outcome. Think about this for our study. The study that you read today, they use this model of a cohort study. They had one group that was exposed and another group that was not exposed. So what were the two groups? What was the exposure group and what was the unexposed or the control group? Community-based accompaniment was the exposed group. That was the intervention that we were following. So we found a group of patients who were in that model, and we followed them over time. What was the unexposed group? Who was the comparison for our community-based accompaniment? So they called it sometimes clinic-based or the standard model. So we had one group of patients who got community-based accompaniment, and we had another group of patients who got the standard model. Those are our cohorts, and we are going to follow them over time to see if their outcomes are different. And Neza, remind us again, when I say outcome, what are my outcomes? So suppress viral load or increase CD4 or attrition. And you will see later that one of the biggest benefits of a cohort study compared to designs that we will talk about later is that you can actually look at multiple outcomes. You don't need to study just one outcome. You can look at more than one outcome in your cohorts, and that's one of the benefits of a cohort study. So in this case, I want to know the difference between community-based accompaniment and the standard model compared to the three different outcomes, which is attrition, suppression of viral load, and increased CD4. So one thing that you need to be careful of is when you have an exposure group and an unexposed group, you want to make sure that the only difference between the two groups is the exposure. So if I have a group of patients in Ringquavu who are getting community-based care, and I have a group of patients in Gisenyi who are getting Ministry of Health care, I want the only difference to be the type of care they receive. I don't want there to be a difference in income. I don't want there to be a difference in education. I don't want there to be a difference in health. I want the only difference to be that this group got community-based accompaniment and this group did not. So you need to be careful that they are only different based on the primary exposure, and everything else is the same. And there is a reason why for this. So in this case, I want to know the relationship between community-based accompaniment and attrition. I have one group who was in Rinquavu who got community-based treatment, and I have another group who is in Goseni who got standard care. What else do you think could be different between people who live in Rinquavu and people who live in Goseni? What are other things that could be different between people who live in Rinquavu and people who live in Goseni? So there are different things that may be different between Goseni and Rinquavu besides the type of treatment that we offer. So I think a lot of these we talked about, so travel time, food availability, depression. So maybe people in Goseni are more depressed because they don't live in beautiful Rinquavu. There may be differences between the two areas. And the issue is that is associated with who gets the intervention and the type of outcome that they might have. So remember, the outcome in this case that we are looking at is attrition. Thinking way back to last Wednesday, what type of bias might this introduce? If there are differences between those who are exposed and those who are not exposed, what kind of bias can that introduce into our study? Confounding bias. And so we have to be careful if there are differences between those who are exposed and those who are not exposed, we could have confounding bias in our study. And I'll show you in this study what they did to control for these potential confounders. So we'll talk about in a bit, they did have confounding bias. How did they control for that bias in their study? Now remember when I showed you that line, they said they used a prospective cohort study. And there's two types of cohort studies that you commonly see. One is prospective, which is what they used, and the other is retrospective. So I want to describe to you how they are different. So for a prospective cohort study, you start at time 1, and you identify individuals who are in your cohort. So I start today and I say, here are 100 people and they are in my cohort. And then I follow those people over time until I measure the outcome of interest. So for a prospective, I start today and I look to the future and I measure the outcome. Alternatively, I could have a retrospective cohort study. For a retrospective cohort study, I start at the end. For a retrospective cohort study, I start at the end. And I look back in time and identify individuals from the past. So I start at the end and I identify individuals based on a list from time 1. So I may say, I want to do a study in the antenatal care clinic and see what their outcomes are. I will start today, but I'm going to look at women who came for ANC a year ago and see how they are doing today. So maybe I look in the register from a year ago and find women who came for ANC. Or I look in the register from a year ago and find women who came to deliver at the hospital. Or I look at the register from a year ago and I find people who came for social supports. I find them from a list from 1 year ago. I go to their files and I measure the different exposures of interest. I take down the data from a year ago and then I look and I see how they are doing today. So what do you think the strengths and the weaknesses are of retrospective versus prospective? Retrospective is faster and it is cheaper, but you are limited in what you can follow to routinely collected data. There are some measurement biases that might be inherent in your data. Things like missing data, Or maybe the person who recorded the data was just lying because they wanted to have good scores. A prospective study, you can collect data on anything you want within reason. You probably cannot collect data on some things, but most things that you want to collect within reason you can collect. But it takes a longer time and it is more expensive. So let me tell you about some advantages of cohort studies over the other study designs that we will talk about later. They can be less expensive, particularly if you are doing a retrospective study. It is a natural history, so I am not going to tell Jeanette if she has to go to this group or that group. She decides what group she is in. I follow her. It is natural. I am not making her do certain things. So it's a very natural study. How do things happen naturally? We saw this with the study that you're looking at this week. You can track multiple outcomes. So the study we will talk about next week, you can only look at one outcome. A benefit of a cohort study is you can look at multiple outcomes. This is the point that Nadine made, which is a very good point. Cohort studies are good for rare exposures. So maybe I want to know the effects of having cervical cancer on your likelihood of death. So how do people with cervical cancer, what is their survival compared to people without? The problem is cervical cancer is a rare disease, and so to have enough people in my study, I need to create a group with that exposure and follow them. And it is easier to do that with a cohort study than it is to do with the other study designs that we'll talk about next week. And then finally, with a prospective study, you can reduce recall bias because you ask the question multiple times. And for this study, they only report on baseline and 12 months, but they actually ask questions at baseline, 3 months, 6 months, and 12 months. So they ask them questions along the way so that people can remember better what their outcome or what the answers are to the questions. Disadvantages. So we talked about this, outside confounders, particularly if the exposed group and the unexposed group are very different from each other. There may be a volunteer bias, which is a type of selection bias. So remember I said Jeanette, I don't tell her what group she goes to, she decides. And she may decide and prefer one group, and there may be a volunteer bias because of that preference. Another disadvantage is you may need to follow for a long time. So for this study, they had to follow patients for 1 year. I've seen 5-year cohort studies where they have to follow patients for 5 years. There is a study in the U.S. where they have been following patients for 35 years. So you may have to follow people for a long time to see what the outcome is that you are interested in. And as a result, you may have loss to follow-up, where we lose people along the way and we don't know what happened to them. And then finally, a disadvantage of the retrospective study, which we talked about, is you can only use routinely collected data. So you can only use what is available. And if what you want is not available, then you need to use a prospective study. So just one last comment on cohort studies, and then we'll come back to the article that you read this week. When should you not use a cohort study? So if there is a long time between exposure and outcome, you may not want to use a cohort study, particularly a prospective study. I have seen studies to do it, like this one in the U.S. where they follow for 30, 40, 50 years. It is very, very, very expensive to track people for so long. You do not want to use it when you have rare outcomes. Cohort studies are very good if your exposure is uncommon, but they are not good if your outcome is uncommon. And we'll talk about next week, what do you do if your outcome is a rare outcome? If you do not have routinely collected data, or if the data quality is poor, you do not want to use a retrospective cohort study because you're relying on that data for your research. And then finally, if you want to show with absolute probability, no doubt, you have no doubt about that it is your intervention that is leading to that outcome, a cohort study is not a good design. You will want to use designs that are much more complicated and that we will talk about in 5 weeks. So these are really good if you just want to observe and follow and learn about what is happening naturally in your clinics. But they can be challenging if the outcome is rare, or if you want to know with 100% confidence this is the effect